Hey everyone, and welcome to today's explainer. Look, if you've ever stared down an electrocardiogram, an ECG, and felt like you were just looking at a chaotic jumble of squiggly lines, trust me, you are absolutely not alone. But what if I told you that an ECG is actually a beautifully organized, coded message? It's literally a real-time dispatch straight from a patient's heart, just waiting to be deciphered. So today, we're going to unlock that code. We're going to transform those mysterious waves into clear, actionable clinical insights, and we're going to do it using a foolproof, systematic approach. So grab your metaphorical magnifying glass because we are about to become ECG detectives. Okay, let's dive right into our roadmap for today. First step, we'll cover the 7-step approach, then decoding rate and rhythm, axis and intervals, evaluating the QRS complex, and finally, the really high-stakes stuff, spotting ischemia and infarction and localizing heart damage. All right, starting us off with Section 1, the 7-step approach. Think of this as your clinical decoder ring. You know, in a fast-paced, high-stress clinical environment, looking at an ECG can feel super overwhelming. If your eyes are just darting around the paper hoping to spot something obvious, you're definitely going to miss the subtle clues. We really need a rigid framework. So this exact 7-step checklist is our foundation. We're going to move methodically, starting with basic rate, then rhythm, axis, intervals, the P wave, the QRS complex, and finally, the ST segment and T wave. By committing to this exact sequence every single time, we safely navigate from just checking basic heartbeats all the way up to diagnosing complex myocardial infarctions without missing a beat. Moving right along to Section 2, decoding rate and rhythm. Basically asking, is there a pattern? Stepping back into our role as clinical detectives, the very first questions we have to ask at the scene are, how fast is this thing going? And is there a pattern? So a normal adult heart rate, which is driven beautifully by the heart's natural pacemaker, the SA node, sits comfortably in that sweet spot between 60 and 100 beats per minute. If it's racing greater than 100, that's tachycardia. Sluggish, dipping below 60, we call that bradycardia. But here's the thing, the rate alone doesn't actually tell us why the heart is behaving this way. For that, we really need to look at the rhythm. And this brilliantly illustrates how we can use a super simple branching logic algorithm to pinpoint the exact cause of a rapid heartbeat. If a patient is tachycardic, you really just need to ask two things. Is the QRS complex narrow or wide? And is the distance between the R waves, the RR interval, is that regular or irregular? A narrow QRS with an irregular rhythm usually points to something like atrial fibrillation or multifocal atrial tachycardia. But, and this is crucial, if you have a wide QRS paired with an irregular rhythm, you are looking at an absolute medical emergency, like polymorphic VTach or VFib. So just by combining width and regularity, you can instantly narrow down a totally chaotic heartbeat into a highly precise diagnosis. Okay, Section 3, axis and intervals. Let's look at the vectors and timing. Now that we've figured out the speed and pattern, we're going to shift our focus to the electrical direction, the vectors. The electrical axis is basically just the average direction electricity travels through the heart. In a normal axis, the main upward spikes in both lead I and lead AVF are positive, meaning they point up. Easy enough, right? But in right axis deviation, lead I is suddenly negative, pointing downward, while AVF stays positive. This visual difference is a massive clue. It tells us that the right side of the heart is working way harder than it should be, which points us toward conditions like right bundle branch block or right ventricular hypertrophy. And just as important as direction is timing. When our electrical intervals are off, they're essentially sounding an alarm. A prolonged PR interval, which just means it takes a little too long for the signal to travel, suggests an AV block. Now, if it's too short, you might be looking at an accessory pathway, like in WPW syndrome. And a prolonged QT interval is a massive red flag for dangerous arrhythmias that's often triggered by hidden side effects from things like antiarrhythmic drugs, standard antibiotics, or even just low potassium. So your precise measurements literally reveal hidden dangers. Which brings us to Section 4, evaluating the QRS complex and assessing chamber size. So we've reached Step 6, where we examine the actual physical shapes of the QRS complex to understand the physical state of the heart's ventricles. Now, what's really interesting about this is how, by looking specifically at leads V1 and V2 on the right side and V5 and V6 on the left, we can actually diagnose structural issues. For example, if you see a surprisingly tall R wave in V1 or V2 sitting alongside a really deep S wave in V5 or V6, that is a classic flag for right ventricular hypertrophy, maybe from something like pulmonary hypertension. The electrical tracing is quite literally painting a picture of an enlarged heart muscle. All right, so this brings us to a really critical juncture. We've looked at rate, rhythm, timing, and structure, but now we have to ask the absolute highest stakes diagnostic question of all. What exactly happens to these squiggly lines when the heart muscle is actively starving for oxygen? Let's answer that in Section 5, Spotting Ischemia and Infarction. We are officially entering the danger zone. This is it, the final and most critical step. We are examining the ST segment and T waves to catch a heart attack in progress. Normally, the ST segment is totally flat. When it shifts, it is screaming for help. ST elevation happens when the segment is pulled upward, and the most terrifying cause of this is a STEMI, a full-thickness heart attack. On the flip side, ST depression is when the segment drops below that baseline, which points to a partial blockage, like NSTSES or even digoxin toxicity. Look, both are incredibly alarming, but they point to distinctly different underlying emergencies. Let's visually anchor this concept. Notice how in these bottom leads, the ST segment is aggressively rising above the baseline. That right there is your ST elevation, the undeniable hallmark of an acute heart attack. But look closely at the leads circled above them. The ST segments there are dipping down. Those are your reciprocal changes. Because the heart is three-dimensional, viewing a massive injury from the opposite side makes an elevation look like a depression. Seeing that ST elevation accompanied by reciprocal depression is the ultimate confirmation that you're dealing with a completely blocked artery.
Finally, Section 6, Localizing heart damage. Pinpointing the cry for help.
Okay, we've spotted the cry for help, but now we have to figure out exactly where it's coming from. It is so easy to just get lost in the grid paper, so let's remind ourselves. Behind every single printout is a beating, physical heart in a patient's chest. The heart has different regions, anterior, inferior, lateral, and every single region is supplied by a very specific coronary artery. Our 12-lead ECG is essentially giving us 12 different camera angles, looking directly at these specific anatomical regions.
So the crucial point is, this mapping table right here acts as your ultimate cheat sheet. When you spot that dangerous ST elevation, you just look at which leads it's showing up in to find the culprit. If the elevation is in the anterior leads, that's V1 through V4, the blockage is in the left anterior descending artery, the LAD. Elevation in the inferior leads, I3 and AVF, points straight to a right coronary artery blockage. And if you see it in the lateral leads, I, AVL, V5, and V6, the left circumflex artery is compromised. You see, you aren't just looking at electricity anymore, you are literally tracing the electrical injury straight back to the exact blocked plumbing.
Well, we've covered a ton of ground today, moving from a rigid 7-step checklist all the way to pinpointing a blocked coronary artery. By systematically checking the rate, the rhythm, axis, intervals, and the specific shapes of those waves, you completely strip away the chaos. So, I'll leave you with this thought. Next time a 12-lead ECG is placed in front of you, will you just see a random jumble of squiggly lines? Or will you confidently step up and decode the heart's hidden message? Armed with these structured detective skills, I have a feeling you're fully ready to solve the case. Thanks so much for joining me on this explainer, and keep learning.